Hi, you have shown the desire to want and to learn some of the complications of trocar cystostomy, or also called trocar suprapubic catheterization. And I shall be talking about these complications into three small presentations. In this presentation, I shall bring forth before you the intra-procedural complications. That means the ones which occur at the time of doing trocar suprapubic cystostomy. Let me also mention here that at this site of the Dalela Uro Academy, you also have a video of showing you how to do a trocar cystostomy separately. Please see that so that you know what is the best way to do this procedure. In this presentation, I am sharing with you knowledge about intra-procedural complications, and I'll talk to you about methods, how to diagnose these complications, how to manage these complications, and the most importantly, what you could have done at the outset by which you can prevent these complications. Before we move on to the intra-procedural complications, let's first of all revise in our mind, when do we have to put a suprapubic catheter? We put catheter suprapubically to manage retention of urine when placement of catheter per urethra is not advisable or is not feasible. You put suprapubic catheter to provide rest to the urinary bladder in some patients who undergo operation on bladder and urethra and prostate, as well as lower ureter, and to give post-operative rest for recovery and for good healing of the lower urinary tract. When bladder does not retain urine well and patient is having urinary incontinence, and you have to manage, particularly in elderly individuals, long-term urinary incontinence, you put them on suprapubic catheter life. And then there may be a situation when bladder can retain urine, but it does not store well. Now there is some difference in retain well and store well. In store well, I mean morphologically it will be able to retain about 200 cc and 300 cc of urine. But then it is storing this urine at a high pressure. The compliance of urinary bladder is bad, and this compliance allows higher intravesical pressure, which is detrimental to the health of upper urinary tract. So you want to put a suprapubic catheter, and this situation arises on some patients of neurogenic bladder. So these are group of indications for which you have to place a suprapubic catheter. Also important to know is when not to put the suprapubic catheter. In patients of cancer bladder, never ever put a suprapubic catheter, because the cancer cells will disseminate along the tract and will worsen the cancer disease. If anybody who has uncorrected coagulopathy, this procedure should not be done. Anybody who has sepsis on the abdominal wall, this procedure should not be done. And anybody who has subcutaneous vascular graft, femoral or ilioiliac kind of, which is running transversely in the subcutaneous space in the lower abdominal wall, that should not be done. Before you do a suprapubic trocar cystostomy, you must, as a beginner particularly, and even if as expert, you must find out that there is no scar in the suprapubic area. Now, if there is scar in that area, you should find out why is this scar, what surgery has been done before, because there are certain kinds of operation which allow the adhesion formation between the bowel and the bladder, right? And if bowel loops are adhered to bladder, then you run a risk of causing injury to viscera. Whether the bladder is adequately full or not, If the bladder is not adequately full, it remains like a compressible balloon. You put the trocar through the abdominal wall, the bladder wall sags because of low tension of urine in the bladder. You become more, the difficulty is there in puncturing the bladder with trocar. Is there a urethral leakage? That means when you push the suprapubic catheter from abdomen and the urethral resistance is low, it is possible that by your pressure, large amount of urine will gush out from the urethra. This may happen in some patients with neurogenic bladder. So you may have to do some way to keep urethra occluded temporarily at least. Is there a chance of autonomic dysreflexia? In some patients of cervical cord injury, when you try and put trocar SPC or any way suprapubic catheter, they can sometimes throw up an episode of reflexia, and then matters can become serious. You must check that somebody or you yourself have taken an informed consent about the entire procedure. The trocar suprapubic catheterization is often left to the junior members of surgical team, the first year residents, house officers, medical interns. Sometimes, they are the ones who do this procedure. So I request that if you are one of them who is willing to do this operation, you should not and you should never underestimate this procedure, because this has complications and these complications can sometimes be fatal. Let us see what are these complications. And I mentioned that the procedures can occur at the time of procedure, immediately after the procedure. They are called early post-procedural, or they can occur even at later stages. In this presentation, I am talking to you only about intra-procedural complications. These complications are these four: intraperitoneal entry with or without injury to bowel, the injury to posterior wall of the urinary bladder, the over-advancement of catheter into urethra, and sometimes cross haematuria. We will see these complications one by one. The perforation of bowel or any other abdominal structure is a really major complication. And you see, when you put suprapubic catheter in those patients where the bowel loops come in front of bladder, sometimes in children, sometimes in thin-built individuals, sometimes in obese individuals, and if this happens, then you can transgress through the intestinal loops and can create really bad injuries. So it is important that you know how to make a diagnosis of this complication. When you have done a trocar cystostomy and this patient is now experiencing lower abdominal pain. Now, following trocar cystostomy, patient should not experience significant lower abdominal pain. But if patient is complaining of lower abdominal pain, and more importantly, as the time passes by, his pain severity is increasing and also the area of the pain is spreading. Initially, it may be by the side of the catheter. After 2 hours, it will be a palm size area. After 1 more hour, it will be a big area of the lower half of abdomen. So, increasing severity and increasing extent of the pain, you should get alerted. If patient starts vomiting, if patient starts showing restlessness, if the abdomen starts getting distended, if there is leak of intestinal fluid by the side of suprapubic catheter. These signs are very easy to spot out. But and it is too late if you diagnose the bowel injury by intestinal leak. You should be able to diagnose bowel injury by the first box, increasing pain and increasing area of the pain. What will you do then? You have to immediately ask for a plain X-ray of KUB area to demonstrate gas in the diaphragm. You must order for an ultrasound of abdomen to demonstrate free fluid in abdominal cavity. Better to do a CT scan of abdomen for more details. And then, if it is only intraperitoneal transgression of your catheter and no injury to bowel, the pain in the lower abdomen was due to urine leakage in peritoneal cavity in a small amount by the side of catheter, then you can, be conservative in your management, and maybe if you have access, you place a urethral catheter in addition to a suprapubic catheter, then that's all you have to do. Along with this, surely you'll have to give conservative treatment, antibiotics and analgesics. But if your suspicion is for bowel injury, and this would be by general signs of bowel injury, you have to explore this patient by formal laparotomy. And sooner you do, the better it is in the interest of the patient. How can you prevent this complication? That's my key area. That's my key interest in this presentation of sharing with you how can you actually prevent it. First of all, you have to be very careful if there is any suprapubic scar and you are going to do a Trocar SPC. Please always have bladder as full as possible. A full bladder displaces bowel loops more cephalad, more towards the peritoneum, and you get a bladder, anterior wall of bladder more close to parietal wall. Avoid a blind technique in small and thick walled bladders. Small is important. Thick walled is also important. In small bladders, the bowel loops can come in front. And these bladders cannot be distended because they are thick walled bladders. If you try to overfill them, the urine leaks by the side of catheter, or they leak wherever it has to. So, have the patient head down, some tilt, because this will allow the bowel loops to go down, and then you can do it much better. If there is slightest doubt, play safe. Have an ultrasound probe in the operation suite in OR and use ultrasound guidance to find out where is the bladder, and to also ensure that there is no bowel in the projected trajectory of the trocar. Okay. Let's see the second complication now, which is the posterior bladder wall injury. How do you diagnose the posterior wall injury? You have done trocar cystostomy, urine drained, you have sutured, fixed the suprapubic catheter. But then you discover after some time that haematuria is setting in. And this haematuria is increasing. The catheter is getting blocked, right? Blood is coming and clot is forming. If that is the scene, then you have to be careful. What is the reason of this kind of haematuria? When you introduce your trocar in the abdominal wall, like that, and you advance the tip of the trocar, the abdominal wall produces resistance to the advancing tip of the trocar. To counter this resistance, we make incision in the skin, subcutaneous tissue, and always in the linea alba. When you cut the linea alba and then you enter the trocar into that hole that you made in linea alba, and now only thing you have to puncture is the anterior wall of bladder. But if you are novice and you are not aware of this thing, you only make incision in skin and fat, and now you are trying to push trocar through the tough linea alba. Remember what may happen. The linea alba will go down like that, and you are using peak of the force, and suddenly it gives way, and your trocar goes deep into the bladder and hits the posterior wall of bladder because your force becomes uncontrolled. The reason was you did not incise linea alba and you did not exercise proper patience. How can you prevent this? And I have already given you a hint. The best prevention is First of all, incise linea alba adequately, make adequate hole, and you see the video in this site, how to do a trocar cystostomy, operating video. There I have already specified this point. You should also, have some kind of a restriction mechanism on the trocar so that it does not over enter the bladder. You can hold it there, put a mark, something you can put on the trocar itself so that it does not over advance into the bladder. Always have a full bladder, because if you have a full bladder, then the distance between the anterior wall of bladder and posterior wall of bladder is more. If you have semi-filled bladder, and as your trocar tip advances, the anterior wall buckles ahead of advancing tip of the trocar. And as it buckles, sags in, the distance between the anterior wall and posterior wall becomes too little. And finally, as you puncture the anterior wall of bladder, at this point of time, your trocar is dangerously close to the posterior bladder wall. But if you have a full bladder, if you have over full bladder, then the dipping of the anterior bladder wall will not occur so much. You avoid blind technique in small bladders. In small bladders, distance between the anterior wall and posterior wall is too little. Please do it under ultrasound guidance or do some other technique that I'll share with you shortly. You must do ultrasound to see the bladder volume, right? That's very important. Let's move to the third complication. This is the over advancement of catheter in the urethra. I don't know whether this has happened to you before ever, but what I mean is this. When you're putting the catheter in the bladder through the trocar, through the cannula, and you tend to, inadvertently push a little more of catheter. There is something in your mind that through the trocar, the catheter may not go completely inside the bladder. So you tend to over push. And when you tend to over push this catheter in the bladder, in some situations, the catheter tip can go in the bladder neck, it can go in the prostatic urethra, it can even go down into the bulbous urethra. And there, if you inflate the balloon and you tug, so initially some urine will come by the side of catheter, but later on this catheter will not drain because the tip is not in the bladder lumen, tip is in the urethra. And that's what is the scene. The catheter from suprapubic root has gone into the bulbous urethra and there is a balloon there. What then should you do? Or first of all, you understand why actually does this happen. Here in this diagram, you see a trocar and a cannula assembly into the urinary bladder. And that's how you are when the bladder is full. The moment you take the trocar out and let the half slotted sheath stay in the bladder, the urine will well out and the bladder will empty on account of the abdominal viscera pushing it from behind. And this trocar gets tilted because the bladder capacity, bladder shape changes, the trocar tilts towards the bladder neck. And look at the direction of the slotted cannula now. It is sitting right above the bladder neck. And when you put the catheter through this, you are very close to bladder neck. And you put more of it, it goes into urethra. So that's the reason, that's the way your catheter is likely to go in prostatic urethra. How do you diagnose this? That over advancement has occurred. There will be failure to drain, obviously. If you try and pull the catheter, there's a feeling of catheter getting stuck there. It's not freely mobile in the bladder lumen. You try to push it in, it neither goes in nor comes out. There's a feeling of stuck catheter. There may be a bleeding from urethral meatus. And if your patient is a female, I have had occasions where I've seen catheter coming out of the urethra and the catheter lying in the vestibular area of the female, out of the urethral orifice. So that's what can happen. How do you manage this? How do you prevent over advancement of catheter into urethra? Or what should you do then? In that case, you deflate the balloon and reposition the catheter in the bladder lumen. Now this is easy, but then your dilemma would be, how do you know that you have come in the bladder and you are not going to withdraw it completely out of the suprapubic tract? So this procedure therefore should better be done under C-arm image intensifier. Inject contrast from the catheter, see where is it, the tip, withdraw slowly, inject contrast, withdraw catheter, inject contrast. The moment you come in the bladder lumen, inflate the balloon. And that's how you withdrawn the balloon back in this patient back into bladder. How do you prevent this complication? You prevent this complication by doing trocar cystostomy in small capacity bladders. There it is more likely to happen. When you are inserting the catheter, don't be a foolhardy kind of person that push catheter. Why are you pushing this catheter extra? You estimate the length of the catheter, let's say about 4 or 5 inches. That's all you have to do. A trocar puncture, put only 4 or 5 centimeters inches of catheter. Don't over pull, don't over push the catheter. And also you can do one more thing, and that's the observation, and that's the trick we have published in some of the journals some time back, that if you keep the slot of the trocar and cannula assembly directed towards the umbilicus of the patient. I hope you recall when you saw this kind of thing, when I was showing you advancement of catheter in the posterior urethra, the slotted side of this cannula was directed towards the penis of the patient or towards the foot end of the patient. Here what I am saying is, you turn the cannula in a manner that the slotted part is towards the umbilicus of the patient, right? And when you advance the catheter, if there is a tilting in the trocar like that, please keep it straight the way it is shown. So before you advance the catheter, 2 precautions. Keep the slotted side towards the umbilicus and keep the trocar straight, and when then you advance the catheter, it's unlikely that it will go in the prostatic urethra. And finally, the 4th complication, and that's haematuria. When you have haematuria case, don't go by what is the amount of blood outside in the tubing of the bag or in your urobag, because a large amount of blood can be within the bladder lumen. So you have to remember that there may be a clot retention in association with the haematuria that you have. Why has this haematuria occurred? That question should also bother you, because bleeding can come from the anterior bladder hole, or there may be inadvertent posterior bladder wall injury, a small sharp cut, a small tip of the trocar incising somewhere or rubbing against the mucosa, may not be through perforation, but a partial injury of the posterior bladder wall which is bleeding. Or is it due to the decompression effect? Decompression means the bladder was very full, very tight at the time of trocar SPC. You punctured and then you allowed the urine to well out, and you took time in taking the catheter, you took time in putting the catheter through the cannula, and in that process, bladder was allowed to decompress at a very fast speed. If this rapid decompression occurs, some bladders bleed. Or is there a chance of a bleeding disorder, which you probably missed? So you have to look into these aspects. What can you do to prevent this? You need to minimize the bladder decompression time. How can you do this? You can do this by, when you are puncturing the bladder and you are about to remove the stellate part, have somebody ready with the catheter. Have somebody ready with the syringe fitted in the balloon channel. Have somebody ready with the urobag tubing attached to the back of the Foley catheter. All this ready. You remove the obturator and immediately insert the catheter. So the time that you give for urine to well out, you minimize that time. And if you minimize that time, the speed of decompression will be lesser and you minimize decompression time. When you put the balloon in the bladder, inflate the balloon and tug the balloon under the anterior wall of the bladder, the hole that you made. Because if you tug the balloon puts pressure on the bladder wall, and if the small ooze from that hole that you made by trocar in the anterior bladder wall, that is on the underneath tamponaded. The another complication, and which is a very bad thing to have, is a balloon malfunction. What does it mean? It means that you put in the catheter in the trocar, urine is leaking by the side of Foley catheter, and your assistant tells you, sir, I'm not able to inflate the balloon. Now this is too bad a thing to have, and this is too late to diagnose once the catheter is in. Please, for heaven's sake, whenever you do trocar cystostomy and you want to put Foley catheter, please have the balloon checked XYO. Let your assistant inflate the balloon and deflate the balloon. Make sure nothing has gone wrong with the balloon. Sometimes the catheter is kept bare in the trolley, sharp objects hit the balloon and balloon is actually broken, ruptured already. Or there may be defect in the manufacturing of the balloon. So you should have, first of all, a very good quality catheter for SPC in that setting, and you should have checked the balloon beforehand. Don't diagnose the balloon malfunction when the balloon is already in the bladder. It's too late actually. If the balloon malfunction has occurred, don't withdraw this catheter. Let it be there wherever it is. Okay? And then try to put a guide wire through this catheter. Now the problem is this catheter may not be end hole, and your guide wire will go and get stuck at the tip of the catheter. But here I would suggest that you keep trying, and you may use not the straight tip guide wire, use an angled J-tip guide wire. Withdraw that thing and put the wire through the Foley catheter. In some cases, you will succeed in pushing this wire through the eye of catheter into the bladder. And then you withdraw this catheter, and over the guide wire you can put in another catheter. Right? But if that has not happened, don't withdraw the slotted cannula sheath till you inflate the balloon. Okay, sometimes some people by mistake, the moment they put catheter in the bladder, even before inflating the balloon, they remove the trocar slotted sheath. This should never be done. Because if you inflate a balloon and you discover difficulty in inflating the balloon because of balloon malfunction, let the trocar cannula, let that slotted sheath be in already. Remove that catheter and try as soon as possible to put another catheter through that place. If your tip of the trocar is in the bladder, still your catheter will go in the bladder. Now this is actually, you will learn these things by doing this practical yourself number of times. So what I said, always check balloon function beforehand, always use a reliable brand of catheter. What is the insertion algorithm that you must remember here? And that's the way to prevent complications. If you have a patient for suprapubic catheterization, you must first of all check that there are indications to do it and there are no contraindications here. If you find there are not enough indications or else there are contraindications, do some alternate bladder drainage method. But if everything is okay, then you see, are you yourself adequately trained to do this procedure or you're doing it for the first time? If you're doing it for the first time, better have somebody more trained by the side or let him do and you watch first of all. Because if you are not trained and your patient is in distress, I would suggest that you put in a needle, aspirate the bladder and reduce the bladder volume. That's all you do, not the proper full trocar cystostomy if you are not trained. By aspirating the bladder, the volume becomes lesser and the misery of the patient is reduced and patient is fine, and later on you can do a suprapubic cystostomy. If the patient has had previous lower abdominal surgery, if you think it is yes, then better to do ultrasound guided or a formal open suprapubic catheter insertion. But if there is no scar, no previous surgery, then you palpate the bladder. You think yes, you can palpate the bladder, then only you proceed with percutaneous SPC technique, the trocar cystostomy technique, I am calling it again and again. But if you cannot palpate the bladder, either you distend the bladder again or you do a ultrasound method. If you can distend the bladder again, you do this by percutaneous technique. If you cannot distend the bladder again, you please use either open procedure or do something, anesthesia or something. If you do these precautions, if you know these complications, if you know how to diagnose these complications, if you know how to prevent these complications, probably you'll do a successful trocar cystostomy. I hope you are benefited by this presentation. Still, if you have any questions, you send to me on my email. Thanks very much.